I think we're all set. I'm Kimberly Bartosiak, and I'm here with Dr. Hannon as well. And we're going to talk about hip replacements today. Thank you all for joining us. We're both at WashU doing adult hip and knee replacements. We do first go around hip and knee replacements as well as revision knee replacements, or second or third time go around for problematic hip and knee replacements. Just a little bit about myself. I grew up here in small town, Illinois. I went to undergrad in the area in Springfield, Illinois, and medical school at Loyola in Chicago. Residency here at WashU, fellowship at Rush in Chicago, and then came back here to start my practice. And then I'm going to turn it over to Dr. Hannon, who's going to give himself an introduction as well.
Thanks, Kim. Great to see you this afternoon, and welcome to everyone who's joining us on Facebook and to those in the future who watch this recorded. My name is Charlie Hannon. I'm originally from New York City and grew up in Connecticut. I went to undergrad at Villanova University, just outside Philadelphia, and went down to DC at Georgetown for my medical school. I then was in Chicago at Rush, where Kim trained for fellowship. I did my residency in orthopedic surgery, and I was there for 5 years. And then did last year my fellowship training in hip and knee replacement at Mayo Clinic up in Rochester, Minnesota. And my wife, Christina, my son, John, and I are really excited to be here in St. Louis and joining the WashU practice. And we have a great group here in orthopedics and specifically in our hip and knee division, where, as Kim mentioned, we really focus on both doing first-time joint replacements for the hip and knee, as well as redo hip and knee replacements for patients who have pain or issues or failures after a hip or knee replacement. But today we're here to talk about hip replacement. So we have a lot to talk about today, and we encourage anyone, if you have any questions, to let us know. But we'll just kind of start out in general. Kim, for most people, they don't really know exactly what hip replacement is. How would you describe a hip replacement to a patient?
Yeah, I think I brought a model today, which I think will be pretty helpful. So think about this as a left hip, where your knee is down at the bottom and your head is up at the top. So a hip replacement is, for the most part, made of four main pieces. So the first part is the socket part. So we take your pelvis and we machine it to a hemisphere. And then we have a metal socket that we put in there, and it fits nice and tight in there. And the bone grows into the metal over the next 6 to 12 weeks. We then snap a plastic liner into it. We do a similar thing on the femur side, or the thigh bone side, where we machine it to a specific size and put a metal implant in there. The bone similarly grows into that, becomes part of your body over the next 6 to 12 weeks or so. We put a head on there that's typically made of ceramic. And now instead of bone on bone, you have ceramic on plastic. Some people, the most common question I think myself and Dr. Hannon gets asked is, how long is this going to last? It's a good question. Historically, people would say they lasted about 15 years. What typically wore out was that plastic liner in there that we talked about. But about 19 years ago, they made new plastic, and the new plastic works a lot better. So the thought is that that plastic will probably be with you for your life, barring any sort of complication or anything like that.
I think, Kim, the other thing to mention too is that ceramic ball is a little bit of a new thing that we've been doing kind of consistently over the past couple of years. I think historically, people hear about hip replacement, they hear about metal reactions, and that was a big thing in the lay press, people getting reactions to the metal, but we really have transitioned to almost exclusively using those ceramic heads, which minimize those metal reaction after surgery. So the advances in technology, I think, with the ceramic head and the new highly cross-linked poly, or that very new fancy plastic, have really limited some of the traditional failure mechanisms that people used to hear about in the past, such as their hip replacement wore out, or they had a reaction to the metal. We really rarely see that those days. I think it's important for patients to realize how things have changed over time. I think it was a great description otherwise.
Absolutely. I think the next thing to talk about, and is important, is when are you a candidate for a hip replacement? When should you have that surgery?
Yeah, so it's a great question. I think everyone, first of all, the indications are different for different surgeons, but I think first and foremost for me, it's patients who are having debilitating pain. And so at the end of the day, patients with hip pain can present in different ways. Number one is, most traditionally, is patients present with groin pain, but some patients may present with pain in their posterior buttock or in their kind of low back area. But traditionally, it's a groin pain. And for any patient who comes into the office, both see you and I, Kim, I know you're the same, is we always try conservative treatment first. And that's things like anti-inflammatories, modify activities, gait aids if you need them. And patients should do that as long as they can. But when patients clinically start to suffer, such that their quality of life really is not the same as it was, and they stop doing the things that they love, and radiographically they have evidence of arthritis, which is loss of that smooth gliding surface or cartilage on their femoral head and socket, then we'd start discussing surgical intervention. And so those are the patients that are really going to benefit from hip replacement. It's not something that we do as if someone has arthritis and no pain. It's really for patients who are suffering from debilitating pain. And those are the patients who really, at the end of the day, love their joint replacement after surgery. What about you, Kim? Do you have any other thoughts on indications?
Yeah, I think you hit the nail on the head there. I mean, for me, I need three things to do a hip replacement. I need x-rays that look like you have arthritis, severe arthritis that I can treat. I need a patient who's done some of the things that you tried about. They've done some activity modification, they've maybe taken some anti-inflammatories, but that's kind of failing and they're unable to do the things that they want to do. Maybe they want to play with their grandkids, maybe they want to golf, maybe they want to jog, all of these things. Maybe it's even keeping them awake at night. And then the last thing is you need a patient that wants to have a hip replacement, because at the end of the day, this isn't heart surgery, it's not cancer, it is still at the end of the day an elective procedure, and I'm not going to handcuff you to the stretcher. You need to want to have the surgery, so you're happy with it in the end.
Yep, I think that's a great point. I totally agree. I think one of the other things that sometimes gets challenging, Kim, that we should probably talk about too, is some patients say, you know what, I have a hip problem, but it may be their back. How do you kind of decipher between back and hip? And I know it's a very nuanced discussion, but what are some of the ways that you use to decipher patients who are having hip or back issue?
Yeah, I think it's really tough sometimes. It's really a common problem. So many of our older patients have both issues going on. I think some of the helpful things to do, and what I like to do, is start with an injection into the hip joint itself. We have our PM&R physiatry docs here do those, and they guide the needle down into the joint itself, and they put some medicine in there. It can help your symptoms for a short time or a longer time, but I think it's helpful for me to know what percent of the pain got better, 10%, 100%. If it's 100%, then I think even if you have a terrible looking back on x-ray, that's coming from your hip. If it's only 10%, then sure, I can put a hip replacement in and give you a great looking x-ray, but it may not help you at the end of the day. Most of it's coming from your back.
I do the exact same thing. It's exactly the way that I approach it as well. So I think the other thing to kind of talk about too is, once patients are indicated for hip replacement, they've had pain for a long time, their quality of life starts to suffer, we've really isolated that they're going to benefit from a hip replacement, and through shared decision-making decide to go through with the hip replacement. There are different types of approaches. And so I think traditionally we talk about a posterior approach. I know, Kim, that's what you commonly do, and I do that very, very frequently. We'll talk a little bit about the posterior approach. We can talk about some of the others, which include the anterior, going from the front, as well as a lateral approach. But I think posterior is most common. So I think how would you educate patients on the approach side of things?
Yeah, so the posterior approach is still the most common surgical approach used worldwide. We've known about it since the 1870s. It was kind of modified in the 1900s to start to be used for hip replacements. Most people actually, when they have a posterior or posterior lateral approach, end up with an incision on the side of their hip and a little bit into the buttock. They can be anywhere from a 6 centimeter incision to a little bit larger. It is a great approach. It gives you great access to both the socket side that we talked about before that you have to prepare, as well as the femur side that you have to prepare. It gives you a good approach so you can put the correct size implants in and in the correct position. It's pretty versatile in the sense that even if you maybe have a bigger hip and bigger soft tissues, that skin back there is in a good spot for healing, and it's thick, good skin for the most part. And we just take the muscles of the buttock and actually divide them in line with the fibers. And then at the end of the case, we actually put them back together. You may hear of it as the muscle splitting approach. The muscles that actually get split are the very short external rotators. So there's these very small muscles that most people don't really know the names of until you get into medical school and start doing hip surgery and things like that. And we put those back on at the end of the case, and they heal over the next 6 weeks or so. I like this approach. It's been used for the longest. Like I said, it's very versatile and it gives you great access. Downsides of the approach are most surgeons, not all, but most surgeons give you 6 weeks of precautions with this approach, meaning no bending the hip past 90 degrees and no crossing the leg past the midline, meaning no crossing your legs across each other. To be honest, most patients that I sign up for a hip replacement have bad enough hips that they can't do these things before surgery. So it's not terrible to ask them not to do it for 6 weeks, just until everything gets scarred in and healed. And then after 6 weeks, you can do whatever you want. Again, some surgeons are moving a little away from that. I think it's prudent in my perspective to let everything heal in for 6 weeks. So I do give my patients those precautions. And I think, Dr. Hannon, you do a fair amount of anterior approach. So why don't you go ahead and fill everybody in about that?
Yeah. So with regard to the posterior approach, I totally agree. I think that's the workhorse approach that we really do for a majority of our patients for hip replacement. It's a great approach. It's relatively easy to do. It's great visualization. And as you mentioned, Kim, it allows you really to put the implants exactly where you want them because you have the best really visualization of both the socket and the stem side. The anterior approach is a approach that's been around for a little while, but I think it's really starting to come into vogue over the past, I would say 10 years. And recently over the past couple of years has become very interested by both patients and surgeons alike. So this is an approach where we go in through the front. So the advantages of this approach are, number one, is that you actually do the surgery under x-ray the whole time. And so as I do an anterior approach hip replacement, I'm getting live x-ray as I'm preparing for the implants and as I put the implants themselves in. And this is both on the socket size as well as on the stem side in the femur. And so for me, when I walk out of the operating room after doing an anterior approach, honestly, the best advantage for me is I walk out, I know exactly where those implants are when I leave the operating room. So my x-ray that I get in the recovery room there's usually never, ever, ever any type of surprises. So I feel really comfortable leaving the operating room with that regard. I think the second advantage, and this is what is most highly marketed, is that there is some suggestion that the recovery may be a little easier. So we don't have to split any muscles. We go in between muscles to do the anterior approach. And there's some suggestion that the recovery may be a little easier. I think it's important for patients to realize is that we're not talking about months. We're talking on the matter of days to maybe a week or two that you may be using your cane or walker less, or you may be using pain medications less. And this may be very different between patients, right? So for some patients, no matter what approach you use, they're going to use a walker or cane for the same amount of time, or pain meds for the same amount of time. But the anterior approach is a little bit more of a soft tissue sparing approach, and it allows for that. But as our old mentor, Dr. Rosenberg and Rush used to say, there's no free lunch. And so there are pros and cons to each. So while those may be the pros, and that's very attractive to both surgeons and patients, there are some cons. And so the first major con I think that patients notice is that there may be an increased risk of wound complications after surgery. And so because we're going in through the front, there's often a lot of soft tissue in that area that may be redundant with the stomach or the tummy, and that can really put the wound at risk. And so that's why I'm very selective in who I offer the anterior approach, because wound complications are more common when you go to the front. And so I really reserve it for patients who are fit, who don't have a very large pannus or larger belly that would be in the way of that incision, because I don't want to risk that. Because when you get wound complications, it increases your risk of infection in the prosthesis. And we really try to limit that as much as possible, because that is a catastrophic outcome. I think the second real risk that you have to talk about with patients when you do the anterior approach is fracture. And so the risk of fracturing the thigh bone or the femur during surgery is a little elevated. Now we're talking on the numbers of a 1%, but that percent is less than what it would be in the posterior approach. It's much less common in the posterior approach. And then lastly, I would say the small risk and it really has no clinical impact on the patient's outcome, is there is a sensory nerve in the front of the thigh that often is cut or sacrificed through the surgery. Patients get that sensation back, but they sometimes will have a numbness area on the side of their leg that has no impact on their function whatsoever. I think the other pro of this approach that I should mention is that the dislocation rate is smaller. And so dislocation is the most common complication we see after surgery. And so anterior approach definitely has a lower complication rate. So I think, as Kim and I both mentioned, there are pros and cons to each. And this is why we really I mention both of them to my patients. And I say, hey, here are the pros, here are the cons, and together we'll decide what's best for you. For some patients, it's really important to them to get back as quickly as possible. They've known friends that got anterior, and we're happy to do it for them. For other patients, I may say, you know what, it's safest for you to go from the back, and that's what I think would be the best outcome for you. And I think at the end of the day, no matter what approach you use, you want to make sure the implants are put in the proper way. Because usually at 1 year, there's no difference in the way that the outcomes are. Patients have no idea when you're walking around. You look at them, you're like, oh, I know you had an anterior approach, or you had a posterior approach. You have no idea. What matters is making sure the surgery is done correctly. And so I think when you're in good hands with someone like Dr. Bartosiak or the rest of our group here, whatever approach they use, you want to go to a surgeon that's comfortable doing that approach, because your outcome will be fantastic with that.
I think that's a great summary, Dr. Hannon. I think the biggest thing he said in there that I think is critical is patient selection. So not everyone should have an anterior approach. There are certainly some patients that are, appropriate for that. And I think that's what he does in terms of his patient selection, is what he was talking about. If you have a fold there, if you have a penis there, it's not a good option for you. And being at a tertiary referral center, unfortunately, sometimes we see those patients that maybe shouldn't have had an anterior approach. and got that infection in the fold. And I think that's one thing in my mind that kind of drives me away from those things. But again, like Dr. Hannon said, they're both great approaches in the right patients. And I think it's important to find a surgeon that's going to do the right thing for you, not treat you as a cookie cutter. And that's kind of what Dr. Hannon was touching on. He talks about, posterior for some and anterior for others. The other thing I guess I would comment on is the x-ray is great. And it's nice that you can do kind of live x-rays when you do an anterior approach. I do also shoot an x-ray for my posterior hips in the operating room. So no surprises on my end either.
I do the same for my posterior approach too. But it is nice when you're doing the surgery to know exactly where you're preparing your implants. But again, there's pros and cons to each. And to be honest, it just depends what you like to do in terms of surgery. I think both do really well. So as I mentioned before, you want to go with the surgeon that you trust and go with their approach that they're most comfortable with. And that's all that matters. So assuming someone decides to go through hip replacement, they get it done, Kim, we're in the recovery phase. What should patients kind of expect in the first couple of days after surgery and then the next couple of weeks?
Yeah, so I think day 0, you can expect to get up, put full weight on the leg. You'll be walking with a walker, no matter which approach you have, but you'll be walking with a walker on the day 0. The therapist usually gets you up and out of bed. Walk around the hospital. Occasionally some patients discharge home same day from surgery. Many of my patients stay one night. It's really, kind of just how people are getting around and what feels safest. Oftentimes just one night in the hospital, making sure that you're safe to go home and safe to do the things that you need to do at home to kind of care for yourself. Usually people have help around the home for about a week or so, at least someone checking in on you. And you kind of act, like you walk to the bathroom, walk to the kitchen, do the simple stuff, but take it pretty easy for a week. After that, it's really just getting back to weaning from that walker and weaning from the cane. And that happens, variable timelines, depending on the patient, depending on your overall fitness level, overall strength, in your other leg, arms, all of these things play a role. But presuming it's just the hip that's an issue, most people get off a walker around 2-3 weeks, and then get off a cane usually around 4 to 6 weeks. In terms of one of the most common questions I get asked in clinic, and I'm sure you do too, is when can I drive? Obviously, it depends on the right versus the left. The right takes a little bit longer to drive because it's your driving leg. But really, it's whenever you're off narcotics. We don't legally clear you to drive, but whenever you're safe to operate the vehicle, I think, that's safe. And usually that's around the, 4-week mark or so. But you're up and walking. Some people do therapy in the home. Some people do therapy at an outpatient center. Really, hips aren't too much hard work with therapy. It's kind of just letting your body get used to using those muscles again. And most people are pretty happy walking around at least by 6 weeks. And some of them are pretty darn happy at 3 weeks. So it's a pretty, not to undersell, but it's a pretty nice recovery compared to some of the other surgeries that we put people through.
Yeah, I totally agree. It's probably the best surgery we do, and patients are the happiest when we do hip replacement because, as very similarly, patients are usually a cane or a walker for about 3 weeks, and after that, they're like, I don't need this anymore. And they come back to your office at 3 months, they're like, oh my God, I love my hip. I think the one thing to consider though is the recovery is a whole year. And so we do tell patients, hey, you're going to feel really good at 6 weeks. At 3 months, you're going to feel like a new man or new woman. But the recovery is a whole year. And so that last, 20-30% of your recovery is going to come slowly up to a whole year, but you'll keep getting better. But again, I think it's a little bit of short-term pain for long-term gain because patients really do love their joint replacement after they have it. They're able to get back to activities that they love, and it's really a great surgery. I think the last thing to talk about in terms of long-term expectations is in terms of what you do after hip replacement. And so Kim kind of mentioned a little bit before about precautions, and so that is something that we're routinely doing here at WashU. Is we recommend people restrict some of their motion that puts them at a compromising position for dislocation after surgery. So we all do that for 6 weeks after surgery, is kind of modify some patients' activities. Really don't want them crossing their legs or putting their knee above their chest. Those are the compromising positions that really put you at risk of dislocating. But after 6 weeks, really pain is your guide, and patients are able to go back to a majority of the activities that they love. We're not really doing hip replacements very commonly in marathon runners, so we're not encouraging people to go back to long-term running. But really low impact activities like playing tennis, golf, going on walks, biking, even brisk walking, things like that. We really encourage our patients to do, and that's why they get their hip replacement, is to hopefully help their pain to get them back to those activities. So we really don't restrict patients in terms of what activities they can do. but we also make sure that they use common sense, and pain is their guide, and do what is comfortable for them to keep them both fit and active.
Yeah, I think that's a great thing to remark on. At the end of the day, we talk about these small risk elevations, and we like to talk about this because we do 2 surgeries. But at the end of the day, this is, hip replacements are one of the most successful surgeries of this generation in all of surgery. So, it's fun for us to try to make them a little bit better, but it's also hard for us to make them better because they're already so good. We do
Exactly.
have a couple of questions in the chat that I think we can talk about. I think one of them here is about weight restrictions. So one of the things we worry about in hip replacements, and we've already kind of touched on, is infection. So that's kind of why we talk about weight, and that's why we care. Is because the worst thing in our mind is to have a patient have an infection, and weight is a variable in that. So we try to encourage our patients to be, quote, optimized and as healthy as they can be ahead of time for surgery, so they can fully appreciate their hip and not have a complication.
Perfect. Yeah, I totally agree. I think at the end of the day, we really have a discussion with the patient about, when would be the right time for them. And there are what I call modifiable risk factors, or things that we can change prior to surgery that can really optimize their outcome. And so weight is one of those things. So we talk about things like body mass index, which is a ratio of your height to your weight. I think patients who are below 40 tend to do better than patients who are above 40 for sure. Things like smoking. Patients, unfortunately, I know it's an addiction and it's really hard for patients, but we really encourage and even offer counseling for patients to quit smoking prior to surgery, because that really increases their risk of complications after surgery. And also things like using narcotics before surgery. So oxycodone, Norco, tramadol, we try to encourage patients to wean off those as well, because all of these are risk factors for poor outcomes after surgery. And that not only includes pain, but that also includes things like infection or the need for revision or redo surgery. So we really work with our patients very closely, not only ourselves, but our whole team. And that includes our nursing staff, our medical assistants, and as a comprehensive team, really work with our patients to make sure that they are in the right shape for surgery. And then we work with them to get them the best outcome possible. We're holding their hand both from the indication side before surgery all the way through their recovery.
Yep. And I think, I don't think we have any other questions. So I think we're going to end it there. Feel free to come in and see us, or reach out to us with any questions.
Perfect. Kim, great to see you as always. And yes, please come see us. We are both downtown here. And we're also seen at the South County campus and at Progress West, as well as at West County in Creve Coeur. And we'd be happy to see anybody. Hope everyone has a great afternoon. And Kim, as always, great to see you. And thanks so much.
Bye.
Take care, guys.